Liz is a pioneer in active case finding, and I think most of you are familiar with her work in Malawi and Zimbabwe. HIV and TB is her passion, and really informing strategies to strengthen primary health care diagnosis.
Thank you. Well, thank you so much, and I'm delighted to be here. Thank the FIND and the organisers for the opportunity to speak. Active case finding. So I almost queried, do we mean active case finding or systematic screening? But I thought, no, let's we'll stick with the old-fashioned term. And as Katerina says, my real interest is in diagnostic intervention strategies, so aiming to improve health outcomes, both in HIV and in TB. Very different diseases, and the work in TB, of course, we're still struggling with a diagnostic. So I had down, I think my first time ever to say, until we have a new point of care diagnostic, we're stuck with X, was probably 2002, and we still don't have it. So I'm going to use the terms systematic screening and active case finding interchangeably. They do mean different things, and I'll come back to that. But really, that's kind of what we're talking about. We're talking about high throughput screening. So why even consider it? And the issue is really the ongoing problems with TB diagnosis that we see at every level of the health system. In terms of prevalence surveys, and I'm going to be frank that I'm coming from a bias, a Southern African bias. So my interest really is in adults and in adults living in high HIV settings. The prevalence surveys show about 1% of all adults in Southern African cities are culture positive, and the same is true in some Asian cities. Now that's a lot. That means every time you go to church, there'll be people, singing infectious particles into the air along with you. But it's sort of not high enough to be an easy task, even with a good diagnostic. And when you then got bad diagnostics, it becomes a real problem. So just showing here, so this is a meta-analysis we've just done about people reporting TB symptoms in settings where there's enough HIV for people to screen for both TB symptoms, undiagnosed TB, and to test systematically for HIV. So this is a meta-analysis of 260,000 participants, and this is the undiagnosed TB prevalence. So again, you're going from 1% with a symptom screen, you're going from 1% roughly up to about 7%, which is kind of a more doable prospect. But you're getting way higher, a big jump up at primary care, and that's kind of what we know for TB. For HIV, you don't really see that. You see high rates, even 20% in the community. And the other interesting thing, so let me just go through that. And the other sort of two interesting points are, one interesting point is the really high risk of death. So if you're looking at risk of death, that jumps up at the hospital level, it's 23% for people who are admitted to hospital with a TB symptom in these surveys, and that's at 2 months. So absolutely massive, and this is with ART, etc. So I have to be careful on my timing, very careful on my timing. But what we know is that routine diagnosis, and again, I think this is something we really have to bear in mind, is far from efficient or same day, even at the primary care level. So again, these are data just from this year in Blantyre. 2,346 primary care patients screened at entry. Do they have a cough? Screened at exit. What happened? So this is a clinic with expert and smear microscopy on site, and we've got same-day treatment in 0.2%. So this is the reality. Maddie Pai's group has just produced these data from India. This is the same everywhere. And basically, it's this requirement for sputum. It just causes all sorts of problems with the throughput of patients, and you really can't screen on sputum. I think that's just the basic lesson. If you can't do the primary care level diagnostic management, you're not going to be able to ramp that up to scale. And we do have these lessons from the 1980s. So again, this is, if you like, active case finding in a community. Don't try and jump ahead of the facility. So you have to bring the facility along with you. You have to do the health system strengthening at the same time before you can leap into the community where all that undiagnosed TB is. So it's a really important lesson. So whatever we're saying for community just has to be at the primary clinic level as well. So most people, when we're thinking about active case finding, we're kind of thinking out at this sort of level. This is Katerina's slide, I think, puts it beautifully. So we've got passive case finding and then increasing kind of intensity as you go out deeper into the community. You know, your costs are going to be up, the number of screens are going to be going up, the undiagnosed TB is going down. But nonetheless, you know, we do think we have to do this. In 2013, we had the policy review based on, triggered by a trial that I was responsible for in Zimbabwe, where we showed undiagnosed culture-positive TB reduced by 40% in 2.5 years by a very simple strategy based on brief inquiry for chronic cough or opportunity to submit sputum in the community and health promotion at the same time. So we saw rapid change on a low-cost intervention, and this triggered this review. Okay, so these three groups are strongly recommended because there's a lot of evidence around them. These other groups, even prisoners, you know, there's actually very little evidence that screening does you any good, and there's quite a bit of evidence because the diagnostics aren't great that screening can do harm. So you can easily get to a stage where false diagnosis outweighs true diagnosis very easily. So this was the conclusion from one of the systematic reviews, because that's Katerina's. So individual and community benefits remain uncertain, and the benefits of earlier diagnosis have not been established. And that's, if you like, why we had such a cautious recommendation here. You know, it's very expensive to do these. If you don't do them well, you can waste a lot of money. And we do know some of the evidence was not just absence of evidence, but there was some evidence of absence. In other words, you can do a big study, you know, do a big intensive effort and have very little yield in terms of the underlying TB epidemiology. So I think, you know, that's a point we have to move past, and I bring it up because at the moment I don't see any sign that we're investing to move past that point. We need some more data to move past it. So what's new since then? Well, I'm happy to say a lot's new. I do, you know, I'm kind of slightly surprised actually having agreed to do this, reviewed all the topics. I mean, there's really a lot that's been out there, and I would just highlight as well TB Reach, so run by the Stop TB Partnership, around innovative diagnostic delivery, so that's very much the active case finding field. But we also have some randomized trials, which were lacking before. So we've had 4 trials showing that TB screening in people living with HIV saves lives. So that's new, and I think, you know, very consistent. You don't have to do an awful lot. Certainly the LAM, which is the one that I've worked with and Kit Dieter's worked with, for hospitalised inpatients, very promising. But we also saw reductions from introducing expert compared to fluorescent microscopy in rural Cholo, and from just kind of tightening up TB screening in ART clinics, where there was no difference there between microscopy or expert, so it didn't matter what you used, but just do more of it. And we've had a number of trials comparing intensified screening, showing that the outcomes for people living with HIV are as good as presumptive TB treatment. So again, I think that's important. So we're kind of getting, you know, I think for HIV, I'm excited by that, and particularly, you know, there's HIV money, and that should excite the HIV people. In terms of the kind of passive TB suspect presumptive TB patient coming to the clinic, again, there have been 6 randomized trials. There, I'd say the results have been less sort of exciting because health outcomes were not hugely improved. What you did find is more complete and rapid MDR diagnosis, and that's what Expert was developed for. It was not developed as a primary diagnostic tool for low rifampicin-resistant settings. But that's good. That's a clear big benefit. There's also evidence for more rapid treatment initiation for drug-sensitive TB, but by that, we're talking about days. So whether or not it's important for the patient themselves. I hope this is. I'm seeing Karen looking at me astutely, and maybe some more accurate. And the problem is there's just a lot of clinician-initiated treatment going on. But probably more accurate. So the treatment that is given better to patients with culture-positive TB rather than negative TB. But little effect on overall case detection and other important outcomes. And then this big question, are we affecting underlying TB epidemiology? There's a couple of presentations this conference actually on this, but nothing, again, very little investment in that. So that's the main problem with that. The trials just haven't been done. So where are my sort of priorities? I think you do have to stratify by the level of the healthcare, but we have to bring them all along. And unfortunately, well, not unfortunately, we sort of have to start from the bottom up. I think so doing that hospital. We're clearly managing things really badly. With those extremely high mortalities. A lot of that is TB death. We do need efficient same-day diagnosis and mortality reduction strategies. And a bunch of that is going to be more screening, better screening for patients admitted to hospital and including HIV testing. For the primary care level, I think the critical issue is the TB active case finding. HIV has come along massively. So a few of the older studies will suggest it's a problem, but I don't think it is now. We're not finding undiagnosed HIV easily at all in Malawi now, simply due to scale up of HIV testing and care. Here, I think this is a question that's going to come up again and again. But again, I think it's kind of hard to treat people who don't have symptoms. Let me tell you that they don't like being told they have TB, and they're probably right in many occasions. So just in terms of management, it's a lot easier to focus on people with symptoms. And cough is, I think people are struggling with the four symptom screen just because everyone has a symptom, it means everyone basically. Cough is it's recommended internationally for infection control purposes. So that is what I focus on at primary care level. Again, everyone's got one of the symptoms here. So we don't symptom screen here. At this level, I focus on cough, and I think it's the TB diagnostic is the real issue. And then in communities, I'll come on to it, but basically you have to know your epidemic. You have to be focusing on high TB prevalence areas, and you need to come up with an affordable but effective strategy. That's a really tough call. And I think what we're looking for there really is the epidemiological impact. It's hard to justify expensive outreach without that. So you're looking to maximise the potential to rapidly reduce undiagnosed TB. We know we can do it. We did it in Zimbabwe. I think there's many suggestions of that, but we have to do some demonstration projects, work out how to target. Spatial mapping is the obvious thing to use, and we have to invest in understanding and measuring the impact on underlying TB epidemiology, if that is still a deal breaker, which it was in that 2013 guideline. So I think that is a critical investment point. So what diagnostics and targets excite me? Well, I feel so bad saying this, but please, can we consider this as our triage test for the moment, because it works really well and it is a diagnostic. The digital X-ray and the computer-assisted diagnostics, it's kind of a retrograde step. I know we're all kind of wanting to move to nano and instrument-free, et cetera, but this does actually work, and it works really well with confirmatory TB testing. I'll just show you some results, and it is the very next recommended diagnostic. in the TB care pathway if you are TB test negative. So it's just bringing that, it's just kind of reversing. Plus, it's what everyone who does serious screening uses. So, why should TB be an exception? The other is the LAM, which we've heard about, absolutely beautiful, point of care with high specificity, more sensitive versions in the pipeline. Again, I'll show a little bit of data. And then what I'd really love to see as an epidemiologist, I'll come on to this after this. This is the target I'm interested in. Now, folks, how do we forget this? 35 fewer TB deaths in 2020. That very soon, that is next year. We haven't heard a peep about it. But we all agreed and signed up to this, So, I'm interested in the 2020 and the 2025 targets. I really am. And I think we just have to race for them before climate change or populist leaders knock us off our perch, which is going to happen. So, this is my interest. And I'd love to see as well is some new diagnostics to aid the kind of epicide. Something to kind of firm up, are these false positives or not? Which could be a point of care biomarker, so to go along, if you're going to treat cases, can we gather a bit more evidence about them to say, yes, they're really diseased? The new skin tests for latent TB infection, I think low resource setting skin tests have been tried and trusted, and there are the new CTB test. And this is what I would really love, tests for recent TB infection so that we can use it to guide the intensity and need for intervention. Okay, so, where are we at scale? This is a primary healthcare clinic in Malawi. So it's kind of pretty rough and ready, but I do think that these three can go. So symptom screen, digital X-ray with CAD, computer-assisted diagnostics, and then expert. And I do think this can be done at primary care level. I think it's part of health system strengthening. And as I said, if you don't provide X-ray here, then patients die waiting for it, as we showed in the CHEPETSA study. Urine LAM for screening all hospitalised HIV-positive medical patients, so that's actually quite a big market already. There's 100,000 HIV-positive admissions in Malawi every year alone, so that's quite a big global market, and hopefully Fuji will expand the remit. But at the moment, I would be hesitant to move below this because it's a test that works really well for disseminated TB, and we don't yet have the proof that it works well for less disseminated TB, and you tend not to find less disseminated TB sitting in the outpatient clinic. You tend to find that in the hospital, and I think that's really clear from all the autopsy data. And then this, so community interventions where there's evidence of affordable impact. The two that we're getting good signals from, digital chest X-ray based, and particularly the TB Reach interventions. Everyone, I think everyone who's using it is really enthusiastic about it. And then, again, I know it's retrograde, but this approach worked well in Ethiopia, well in Malawi. We're really seeing impact in terms of increased diagnoses. Just going back to the X-ray, so let's not say we can't do it. Here we are, Cape Town. They maintain, thank you very much to Sabina for giving me this slide, but, tens of millions of X-rays were done in the last century, including in resource-poor settings. So if we want to, we can do it. And you do get a good yield, and you do see evidence of epidemiological, suggestions of epidemiological impact wherever it's used. I don't know how well this is projecting. Not very well, sorry. But so this is kind of a normal chest X-ray, just for the clinicians in the room. I'm not going to show you the CAD because it doesn't project well. That is a big pleural effusion affecting that part of the chest. And this is someone with HIV, TB, sort of typical kind of scattered patches, and a cavity in the right apex. But slightly unusual looking for HIV-negative TB. So it is the next step anyway on the smear-negative algorithm. So I just point that out. 90% of patients are supposed to have it regardless of, you know, if they test negative. So why are we withholding it at the screening stage? The capital costs are really falling. It's got the same technology barrier as flat screen plasma TVs. So, you know, there's something that's really driving that price down that we can benefit from. And once you've got going, there's minimal per test costs. If you add in the computer-assisted diagnosis, so that basically does what I've just done. It looks at the lung fills and texture and gives an abnormality score. This is CAD. This is back from 2015 with 7 expert readers. So it's as good as an expert reader, which is pretty good. And you know, the current the ROC for sort of performance against culture looks pretty similar, actually. The higher you are, you know, the more likely you are to be culture positive. There's sort of publications coming out, and I think this is a field that's going to grow hugely. But if we could please embrace that in the diagnostic fold, because at the moment I don't think it's got a home. And, you know, it's like the old days when you have to rely on, you know, which, you know, culture system to buy based on what the reps are telling you rather than based on what Fine's telling you. So, you know, I really think it's important that we embrace this. That's problematic. Sorry. So, liporama, okay, LAM. Okay, so just to mention, we have a guideline. Well, hopefully there's going to be a guideline in review in 2019 that will move this, the recommendations forward. Just to mention Steve Lawn, my colleague who died of a brain tumour in the middle of a STAMP trial that was very much his baby. 2 things that he said that definitely occurred. First of all, that a lot of the benefit is from people being able to produce a specimen, whereas sputum is difficult, as we know, and also that you're going to get a big extra yield from LAM. So, if you like, this is the group, but I would like to have a kind of some straightforward biomarker that we can say, yes, we think this probably is TB, but at the moment. We do, you know, what we powered it around was mortality because it's unequivocal. You know, you want fewer deaths rather than diagnostic yield. So, if you can just, but you know, I think we're there. You know, I think we've got like good engagement, or not. We're nearly there. We've got good engagement on the advocacy, and I think we're going to see the scaling up at country level pretty quickly, driven really by the HIV programme. Mainly. This is the data from STAMP, and I just want to point out, so we did power for mortality, because as I said, it's kind of unequivocal. You definitely always want less. We had 3 predefined high-risk groups. Each one looked pretty similar, where you're seeing, you know, quite a substantial reduction in mortality from a TB screen, and this includes people without any TB symptoms who may not have TB at all. So this is just all admissions to hospital with HIV, well, HIV diagnosed on admission or known beforehand. And I think this is the other of Steve's hypothesis, that people were being discharged undiagnosed. And I think these data support that very strongly, where you're seeing this diverging lines in survival later on when most patients have been discharged. So that's pretty awful, isn't it? You go into hospital and you're discharged with undiagnosed TB. For TB diagnosis, that was increased 1.5-fold. But as I sort of alluded to on the previous slide, this includes isolated LAM positives. Okay, so what about community-wide active case finding? I think I'm going to. This should be quick now. So I think there's, you know, I think we've got 3 indications that I'd like people to consider. So the first one is where the government has a special duty of care. So this includes health workers, minors, prisoners, and the military. You know, groups like this. Some people would put school kids in too, where undiagnosed active TB is extremely high. So, you know, 2 to 4%. So there you've got a number needed to screen of about 25, basically, a really low number. Would you want to live in that community? If you were asked to vote, would you like to have a screening program introduced? I would be begging for it. We see a major cause of death, horrifically high TB, childhood TB incidence, and extremely dangerous to people living with HIV. So I don't know why we're not doing more about this. And then you've got the sort of most of the world, which is this kind of below the 1% level. For these, I think, again, I think we should be doing really aggressive interventions now, aiming to at least, bring that curve, bring the epidemic curve down while social determinants, structural interventions, etc., come into place. And very much, working in the facilities at the same time as any community outreach. But we know that the community outreach works, and we would need to have a system to stop or reduce frequency when the yield falls. This is less clear, but I think we also essential if we're going to meet those goals by 2020 and by 2025 even. And here, I'll just whiz through this. I think it is more difficult. We do have to say this, first do no harm. It's easy to do harm. Needs very careful planning, but a lot of promise. And there's lots of these now. You can double case notification rates. So this is just us from Zimbabwe, that same intervention that we used, in Malawi, the same intervention we used in Zimbabwe, doubling smear-positive case detection, partly by pick-up in the field, but mainly by a sort of behaviour change effect, leading to better health-seeking behaviour. So what we call an indirect effect, and we've got evidence for that. But these are everywhere. You see these. This is TB Reach, Amikan, the Ethiopian model, etc. And I think we just need to sort of think through and ask these questions. Really avoid high test costs if the number needed to screen is high. So that's the problem with expert. And again, you really need these high throughput systems. So what? I think that's my conclusions. So what do I think? Okay, we're at the stage of being able to support rapid scale-up. I do think that's true. I think we need to do it. I would be hoping we'd see a WHO review, guideline review triggered fairly soon. So does the evidence now support more aggressive strategies than it did 5 years ago? Certainly seems that way for me. While we wait for the perfect point-of-care diagnostic, I would like to see us, really getting behind these interventions that we know do work and scaling them up, especially in the high HIV settings where there are vulnerable people living alongside, and to evaluate new diagnostic needs in the context of that scale-up. In terms of evidence gap, I think this is still the big one. Can we reduce the TB epidemic by case finding? And I'd just like to acknowledge my main collaborators and also my funders, mainly the Wellcome Trust. I'll leave on that slide, which I don't know, should we leave it up for discussion? Or is that possible?
I think that's good. Thank you so much, Liz. I think your passion for this topic was obvious.